great to see so many familiar faces. Welcome to Virtual Morning Report. I have some very sad news. It's not really that too sad, but it's sad. My older brother is driving. He's driving back from Pittsburgh, going back to Chicago, and unfortunately cannot make it. So I'm going to be in the lukewarm seat solo today, but I have no fear. I have no fear because we're going to try to make it interactive by involving the chat as much as we can. If you've ever been on the Saturday Virtual Morning Report, we actually involve the chat continuously, and I'll try to replicate that model here today. So while I will be the sole, I hear a vacuum in the background, which is never good news. I will be the sole culprit if things go awry, but we'll rely on you in the chat. And it looks like my dear friend Sammy has a case to discuss. Sammy, please unmute yourself, introduce yourself to the VMR community, and we'll actually just have Gabby take the screen over afterwards and jump right in.
Hi guys, can you hear me?
Yes, we can, very well.
Perfect. Hi, my name is Sammy. I'm a fifth-year medical student from the Medical University of Graz in Austria, in Europe, so not Australia. We don't have any kangaroos here.
Wait, hold on. You have to explain why. Does this happen a lot?
Yes, that happens a lot.
Really? Okay, tell us a story where that happened. I'm really curious. What was the...
Yeah, for example, some in my childhood or when we traveled, and people asked us where we're from, and we said Austria, and after 10 minutes of conversation, suddenly they're like, yeah, but how long did it take you to fly over here? You have to travel a long distance. And we like, no, we're from Austria. It isn't like... Yes.
Amazing. So it's now part of your introduction? Is that what happened, Sammy?
Yes, sometimes.
I love it.
And yeah, I'm just a huge fan of the clinical problem solvers and already had the privilege to discuss 2 times here, I think. And I wanted to present quite a tricky case that was presented at the CPC at our university like 1 year ago.
Amazing.
Yes, and I'm happy to have you discussed it, and I prepared it and would like, yeah.
All right. Challenge accepted, as Travis said. Even though it's not a challenge at all, I'd say that we're all going to have a lot of fun together. My goal, I'll tell you, I'll be very explicit. My goal was to discuss the case, but also highlight thoughts and reflections in the chat. If you've ever been part of a discussion, you'll appreciate just how hard it is to keep track of the chat and to discuss at the same time. So I will inevitably fail in trying to point out comments and whatnot. I'm setting myself up to fail. So I hope you'll forgive me if I overlook a comment, or we'll use the guidance of people who've been here in the chat a lot to emphasize something else that I may have missed. But we're going to do this together, all 55 of us. The only voice that'll be, well, actually, no, I'll ask you, by the way, on the chat to just be ready to unmute yourself. There's no shame at all in getting your voice out there. And we tend to do that on Saturdays, and we'll do it again today. Okay. The Kushal, you don't need Dr. Google. You are, by Dr. Google, that is essentially you, my friend. All right, I'm going to close the window here because it's a little noisy outside. And then, yeah, Gabby, take the screen away, and we'll reflect on Sammy's case.
Yeah, Gabby, and if I'm talking too fast, just I'm gonna just send you the information. Just 1 second. Okay, so Elocott 1, we have a 54-year-old male that gets sent to the emergency department by his primary care physician because of a sodium of 118. And his wife is with him, and she reports that he's fatigued since 1 week and progressively fatigued since 1 week. And in the morning of the presentation, he appeared disoriented and didn't recognize her, and that's what prompted her to consult the primary care physician. And yeah, that's basically the first information you get.
Incredible. I got to tell you, I've been lucky enough to be doing this whole CPS gig for a while now, 2 years almost, and no clinical problem solving case starts with a sodium of 118. And that's because hyponatremia usually is reflective of an underlying disorder. And I'm really struck by the fact that the sodium is the chief concern. What kind of diagnostic mystery is heralded by sodium as a chief concern is actually a very intriguing short list, which I won't share now because it wouldn't be what's happening in my mind. It is true, though, that we have to stop for a second and say, well, how did we even know to check a sodium? And that's where it seems that the patient has had some disorientation. And the first question is, we have two things. We have disorientation, we have sodium. Are they connected? And it is virtually impossible, I think, for somebody to have a previously normal sodium and go down to 118 without being symptomatic in some way, shape, or form. So it is very plausible that the sodium accounts for the symptoms that brought the patient in, but we have to remember that there are central nervous system disorders that can lead to hyponatremia. So there may be a two-pronged attack causing this disorientation. Another problem that causes both encephalopathy and hyponatremia, but I think it's a reasonable place to start and say, okay, the hyponatremia is the cause of the mental status changes. And as Gabrielle highlighted, the key question is what is the time course of this? And I'm going to reflect on Kushal's comment in a moment. And it's the following. When we say hyponatremia, what we're really trying to say is hypoosmolarity. And when we say hypoosmolarity, the real problem is there's too much water in the blood. So fundamentally, what hyponatremia represents to the treating clinician is water toxicity. Water is toxic to our bodies in excess, and excess water bleeds into the brain, causes cerebral edema, and that's a problem. There are a few cases, and Kushal's list is the exact perfect list of when the sodium no longer represents the near total amount of osms in the body. So if you're going from low sodium to hypoosmolarity to water toxicity, which is usually the analysis we're doing, you have to stop and say, are there situations where sodium no longer represents the majority of osms? And that is when you have buildup of glucose, lipids, paraprotein, mannitol, etc. Now, why is it only those substances? Why is it only glucose, lipids, protein, mannitol? It's because you cannot build up any other substance to such high degree to compete with sodium as an osm without dying from it in the first place. The reason that potassium isn't on Kushal's list is if you accumulate potassium enough to contribute to osmolarity, you have bigger problems. The reason nothing else is on that list is because these are the short list of things that can accumulate to the degree of sodium without killing somebody. That's why. But here, I think there's really no reason up front to question the sodium to osm connection. So this patient is water toxic. And the question is, where is this water coming from? There are 5 reasons to have too much water. 5 reasons. You're drinking too much, you're eating too little salt, you have thiazide diuretic on board, you have kidney disease, and you have ADH. All of those alter the balance between water intake and water excretion. Your kidney's ability to excrete water comes down to 4 variables. How much salt, how much dietary osms you take in, how much thiazide you have on board, how much GFR you have, and what your ADH is. Those influence how much your kidney can excrete, and how much you drink. That balance determines whether you become water toxic or not. If your kidneys are working phenomenally well, 1000% well, it takes about 12 liters of this to overwhelm them. 12 liters. Everyone who's hyponatremic is drinking too much water. The question is, too much water relative to what? In a normal, perfect circumstance, 12 liters is too much. And if any one of those 4 things is impaired, dietary osm intake, hydrochlorothiazide, kidney function, and ADH, your ability to tolerate water lowers. If your sodium is 118, you've drank too much water. And the question is, too much water relative to what? We have to find out, does this patient not having dietary salt? Is this patient dietary osms? Does this patient have hydrochlorothiazide on board? Does this patient have kidney impaired function, or does this patient have ADH? Now, let's be real. When the sodium is this severe, there's a high chance that it'll involve ADH in some way, shape, or form. And so I'm already starting to think, is this ADH going to be appropriate or inappropriate? And the one emergent cause of inappropriate ADH that I want to think about right away is adrenal insufficiency, followed closely by cancer. So my priority now is you got to think about management of the sodium. It's so severe that I know that one of those four things is happening: dietary osmosis, hypochlorothiazide, chronic kidney disease, ADH. The severity prioritizes ADH. The question is it appropriate or inappropriate? The severity of the hyponatremia suggests SIADH from that alone. And then the question is, what are the common morbid causes of SIADH? And that's cancer and adrenal insufficiency. We'd love to hear more. I'm going to scroll through the chat to see if there's anything else. But I honestly think you all should just read it. It's beautiful. The comments about pseudo-hyponatremia, references to the Core IM podcast, which is really, really good. I highly recommend it. Anne Marie highlighting high protein as a cause of pseudo-hyponatremia, and just a bunch of pearls. So, Sammy, let's hear more.
Yeah, great discussion. I sadly don't have a earlier value of the sodium. We're just gonna have to take it as it is. But he has a history of lower back pain since several weeks, for which he received an MRI, which showed spinal disc herniation at the L3, L4 level. It got treated with an operation with an interlaminar fenestration and discectomy. The patient reported post-operative constipation, which led to a colonic lavage. And after the operation, his sodium was 123 and was classified as delusional hyponatremia. Otherwise, he had no post-operative complications. And was discharged 5 days later. And so the day he's presenting today is now his 8th day after the operation. So he was 3 days at home, and today is the 8th day after the operation. For his past medical history, he has chronic constipation, which was always hard to treat. And 6 months ago, he had a presumed urinary tract infection. With macrohematuria and lower abdominal pain. There is no information if it was treated. Yes. For his meds, he's taking Tylenol and pantoprazole. Family history is non-contributory. For his social history, he is a musician. He has no allergies. And for his health-related behaviors, he doesn't drink alcohol because he's always having bad headaches and abdominal pain afterwards. He doesn't smoke and doesn't use illicit substances. And for his other review of system, he denies fever, cough, night sweats, weight loss, diarrhea, chest pain, dysuria, or other episodes of urinary abnormalities. And that's the end of Aliquot 2.
Oof, wow. There's a lot of intriguing data here. And I'm just going to try to approach it in the way you presented it, Sammy. I think hyponatremia following surgery is not too surprising. Surgery and the medications used to treat the postoperative pain and nausea are common triggers of SIADH. And I think that our surgery colleagues see it so frequently that they are excellent at managing it. And the good news is with the cessation of antiemetics and the pain control after surgery, the hyponatremia tends to resolve. So, you know, if the sodium is new in the context of the surgery, the overwhelming odds are there might be a component of appropriate ADH from volume losses in the surgery, but not too surprising to understand that there might be a component of inappropriate ADH secreted by the surgical process, the pain associated with it, or nausea associated with it. So that is a working hypothesis that is weakened by the fact that the sodium worsens as the distance from the surgery lengthens. Though that the surgery, it's putative to think that the surgery may have served as an initial cascade to unravel what was probably a prior propensity for this issue. Constipation is not uncommon, but the age of the patient warrants question for a secondary disorder. People over the age of 70, there's about a 30% risk of constipation, the severity of which here and the age of the patient prompts a lot of analysis to why that may be the case. We understand a constipation, secondary constipation, which may not be present here, but certainly worth investigating as either an anatomic obstruction problem or a motility problem. And anatomic obstruction issues, things like large bowel obstruction, volvulus, et cetera, present much more acutely than the chronic refractory constipation. So here you're probably dealing with a motility issue if there is one. And motility issues actually are more common to be meds and electrolytes, things like opiates and anticholinergic medications, and rarely hypercalcemia and hypokalemia. So here already, since we mentioned SIADH as a perineoplastic process, I'm starting to wonder whether there's been low-grade hypercalcemia as a contributor to this constipation. But after meds and electrolytes, there's the frequency of the disorders plummets to neurological disorders. Things like lead toxicity, acute intermittent porphyria as rare causes, more commonly things like Parkinson's disease. Just admitting somebody from the meeting room. And there are disorders that directly impact the enteric muscle, things like hypothyroidism, scleroderma, and inherited diseases. So what can you do with the constipation? The age and severity are unusual for a 50-year-old to be this severely constipated. And it's overwhelmingly likely a motility issue than it is an obstruction issue. And the motility issues are meds and electrolytes, calcium being the notable one that presents in a systematic manner. And neurological disorders also deserve some credit here. Most commonly Parkinson's and diabetes, but others as well. Most intriguing of all is a diagnosis of a urinary tract infection in a middle-aged man that presents as macroscopic hematuria. Doesn't add up. Is it possible? Yes. What's wrong with it? Macroscopic hematuria as a presentation for a urinary tract infection is rare. Macroscopic hematuria may not be macroscopic hematuria. What we really know is the patient noticed red urine. And so the first check is to make sure that you're not missing things like exogenous intake of foods or meds that look like red, or rhabdo, or the mistakenly thinking jaundice is actually blood. I've been fooled by that before. So the first step is to always make sure that you're not dealing with another substance that isn't red. But if it is in fact macroscopic hematuria, you got to worry, because macroscopic hematuria carries a 40% risk of renal malignancy. But if you remove that and you approach it systematically, macroscopic hematuria represents a disease either in the kidney itself, in the ureters, or in the lower collecting tract. And in the kidney, it might represent a mass or a vascular phenomenon. The vascular phenomenons being renal vein thrombosis, rarely glomerulonephritis, and even more rarely renal artery embolism. All of those are painful. They may reflect a disorder in the ureter, like a stone, or may reflect a disorder in the bladder, like cancer or a bladder stone. But this macroscopic hematuria attributed to urinary tract infection is weak, and that requires exploration. You can study that by understanding what the risk profile for malignancy is, and ultimately you'll need imaging to understand what that was. So where are we? We're in the world of pronounced hyponatremia with leads of unexplained severe constipation, unexplained macroscopic hematuria, and this seeming propensity to get hyponatremic with surgery. Clarity needs to be obtained on the constipation and on the hematuria, and probably will come with understanding the sodium better, looking for simple clues on the basic exam and laboratory evaluations. But I have a hard time not wanting to image this patient to understand what the source of that macroscopic hematuria is. I'm realizing that my promise to keep up with the chat and discuss this very complicated case just not going to go through. So please pay attention to the chat because the case is way too complicated for me to do both. All right, Sammy, back to you.
Yeah, nice discussion. So for the vitals, he was afebrile. His heart rate was 75 beats per minute. His blood pressure was 151/81. His respiratory rate was 19. And his SpO2 on room air was 98%. General exam, he had a normal appearance, no acute distress. For his heme exam, he has had moist mucous membranes, no conjunctival icterus, no cervical lymphadenopathy, and no pupillary abnormalities. His cardiovascular and pulmonary exam were unremarkable. No murmurs, rubs, or gallops, and clear to auscultation bilaterally. For his abdominal exam, he was non-tender, non-distended. Liver and spleen were non-palpable. For his neurologic exam, it was basically normal except for a sensomotoric deficit at the left L5 dermatoma. And soon after the examination, he developed acute psychosis. I don't know how it's pronounced, psychosis, and with hallucinations. And was transferred to the ICU and received sodium chloride tablets. Yes, do you want to reflect on that or get more data?
I think it's not too surprising that the pathology here hasn't risen to the surface. I think things that we're entertaining about are so deep in, like the constipation and the hematuria, that a cutaneous signature, but that you can hear, feel, smell, is not too surprising. And I think that the major reflection is that the deficit has been verified that required surgery, which is understandable. Because I think one thing to always track is the marriage between radiology and neurology is a weak one. And just because somebody has chronic back pain and you see something on their MRI doesn't mean that that was causing it. But you discovering a motor deficit attributable to that lesion supports that connection. So to summarize, somebody has a neurological deficit and you see something on MRI doesn't mean they're connected. A lot of people have a lot of incidental discoveries. And so your exam verifies that the surgery seemed appropriate. And I think that the main thing that I'm tracking diagnostically is I'm pausing, constantly checking the temptation to attribute all the neurological symptoms to the sodium, which in real life is probably a good working hypothesis, but you have to be open to something neurologic underneath causing sodium and neurological issues independent of each other. So that's the temptation. I'm really curious to see what happens with the mental status as the sodium is normalized and to see what laboratory signature this disease has.
So they got more data for labs. He had a white blood cell count of 8.3 with a normal differential. His hemoglobin was 13. And his platelets were 155,000. MCV was 77. His sodium, for what we all been waiting, was 114. That was, I think, before the tablets. His potassium was 3.5. His chloride was 73. I sadly don't have a bicarb, but BUN was 17 and creatinine 0.8. His total bili was 1.1. His alkaline phosphatase 74. his GGT 75, AST was 33, ALT was 35, LDH was 330, his calcium was 8.9, glucose was 103, INR was 1, APTT 27, total protein was 7, albumin was 4.3, he had a uric acid of 3.6, that's on the lower limit of normal. His serum osmolality was 241. His urine osmolality was 471. His urine sodium was 128. His urine potassium was 24, and his urine chloride was 112. That's the end of aliquot 4.
Right. So let's focus on the sodium. 114, really bad. You have symptomatic hyponatremia. The management here is aggressive, normal 3% saline, almost certainly in the ICU. That's probably what you'd be doing in real time. But let's study the sodium for more certainty. We got in the urine osms, and the urine osms confirm that the hyponatremia is hypoosmolar. So if you're looking for a secret mimicker like paraprotein or hyperlipidemia, that now has been excluded. So we're squarely in the hypoosmolar hyponatremia, and we found the source of the reduction in water excretion. The only thing that concentrates the urine more than the serum is ADH. And so ADH is on by virtue of the fact that the urine osms are higher than the serum osms. And now the question is, what is triggering ADH? Is it appropriate or inappropriate? And ADH is only appropriate triggered when aldosterone is also triggered. So again, if ADH is on, how do you know ADH is on? The urine osms are higher than the serum osms. Question is it appropriate or inappropriate? The only time that ADH is appropriately triggered is when aldosterone is triggered at the same time. How do you know aldosterone is on or not? The urine sodium. A low urine sodium is a sequelae of aldosterone's action of reabsorbing sodium. And the exceptions to that are when you have diuretics on board that trigger hypoaldosteronism and when you have cerebral salt wasting, none of which seem to be at play here. So we're squarely in the world of SIADH. Most SIADH is from pain and nausea, psychotropic medications, none of which seem to be a good working hypothesis. On day 1 postoperatively, sure. Day 8 or 9 or 10 or wherever we are now. So now you really have to look for those sinister causes, cancer, endocrinopathy being the most common. But then you have to step back and be like, okay, could there anything else that secrete ADH? And that's where we were talking about the neurological axis. So I think all those things need to be tracked. Could this be an endocrinopathy, adrenal insufficiency? Is this a occult tumor that's now surfacing? And is this a neurological disorder? Now let me be more clear about what kind of neurological disorder. A range of neurological disorders from the brain, like limbic encephalitis, to the peripheral nervous system are notorious triggers of SIADH. Limbic encephalitis, I just said, but then acute intermittent porphyria, lead toxicity, and things of that nature. What do we need to do to make progress? I think the endocrine axis is the easiest to test serologically. And then you really have to try to peel the curtain behind all the things, all the potential clues that are laid here. And what are those? The microcytosis is one clue, the unexplained macroscopic hematuria, and the constipation. Microcytic anemia in this context, microcytic anemia in general is iron deficiency anemia or thalassemia. Iron deficiency in this context prioritizes lead toxicity. Chronic constipation in this context, prioritize lead toxicity, but also think about acute intermittent porphyria, which may present with macroscopic hematuria, but what's really red is the porphyrin. Adrenal insufficiency, you got to think about it here. Hypothyroidism, you got to think about it here. So where do we go next? I think you have to get a heavy metal screen. I think we should look at the abdomen and pelvis to study what this chronic constipation may be and what this macroscopic hematuria may be. And if the sodium normalization still, if the mental status is still an issue despite sodium normalization, you might study the neuraxis. But I think the focus in real life is on the management here. So let's fix that sodium. Let's get iron studies in and think about lead toxicity, think about acute intermittent porphyria. And I'm really curious to see what will be left after the sodium is addressed in terms of neurological symptoms to guide us further. All right, Sammy, back to you.
Awesome discussion. I'm just, don't know what to say. Really good. So he had an ECG which showed normal sinus rhythm. He got a CT of the chest which showed a small atelectasis at the left lower lobe. Otherwise normal. Lung parenchyma and unremarkable CT scan. He had an MRI of the brain which showed small microangiopathic changes. No signs of recent ischemia or structural changes. The abdominal X-ray showed meteorism and large stool burden. Large stool burden. He had a lot of stool in his intestines, yes. And the MRI of the lumbar spine showed postoperative fibrotic changes and was otherwise unremarkable. He also had a TSH drawn, which was 3.4. And morning cortisol was 23. And psychiatry was consulted because of the progressive delirium, and he received risperidone and pregabalin. And that's the end of the last aliquot.
Ooh, the end of the last aliquot? Oh yeah, I'm really gonna count on you. So if we anchor ourselves in the world of SIADH, we anchor ourselves in that world. I think that the easiest thing to test for is the endocrinopathy and the normal TSH here and the normal. Hold on one second. The normal TSH. Here, one sec. There's a lot of work happening in there. Sorry. So where are we? I'd say that adrenal insufficiency, probably not. Almost certainly excluded with an AM cortisol that high. The TSH is in the normal limit, so I think we can move past the endocrinopathy. And the two other leads we were tracking were, is this a paraneoplastic process as a result of a variety of malignancies, most notoriously small cell carcinoma? The problem with small cell carcinoma is that it really can evade detection. The word small cell actually describes its histopathological appearance, but you can sabotage that word and realize that the cancer actually may be microscopically small and evade detection. So the small atelectasis in the left lower lobe, is that signal to a microscopic tumor there that could result in this? And a PET CT scan would be the next step to evaluate that process. The fact that the MRI brain is normal is reassuring, but the problem is that the limbic encephalitis that we be entertaining actually are notoriously MRI and even occasionally lumbar puncture negative. So it's hard not to remove the endocrine hypothesis. And the question is, do we move away from the cancer hypothesis altogether, or do we recognize that the imaging that we've done is imperfect and may be missing something? The question is, where do we go from here? I think, given the morbidity of the of untreated or undiagnosed cancer, I think we have to look further for that. And so a next step might be a PET CT. But it's hard not to study the time course of this syndrome. And the time course, if it in fact ties in with the chronic constipation and the presumed urinary tract infection, seems to be stretching so much longer than a malignancy would show up as. Especially a malignancy showing up this hectically now might be expected to have began much earlier than the chronic constipation and the macroscopic hematuria would have you believe. But it's very plausible that the chronic constipation is chronic idiopathic constipation. And this one episode of macroscopic hematuria turned out to be just one random episode that's not linked with the current clinical syndrome. It's really, really hard to plot out how this would evolve and how an answer might be revealed in the next aliquot. And that's, I think, the unfortunate bias that we all have in clinical reasoning, is we know that Sammy does a test that tells us the answer right away. But I'm going to slow down and summarize. We have a middle-aged gentleman who has a long-standing history of unexplained chronic constipation, who, after appropriate surgery for lower back pain, has marked progressive hyponatremia and SIADH. Does that trigger anything for anybody? Slam dunk diagnosis? I don't know. But for me, it's hard not to worry most about cancer, but it's hard to ignore the microcytic anemia and the constipation to make me worried about lead toxicity. So it's hard. I don't think anyone can commit to an answer now. But what would be good next steps or wise next steps? I think there are three of them. The first is to consider malignancy and get a PET CT scan. The second is to consider acute intermittent porphyria, talk to the family, and review that diagnosis of macroscopic hematuria before for clues as to whether that was blood or not. But most of all, I think the low MCV here might be the tip-off to lead toxicity, and a heavy metal screen might take us to where we need to go. So if I really were to stay authentic to being able to learn the most from it, I would push myself to put my nickel down. And my nickel is a very soft, cheap, stolen nickel that's on lead toxicity. And I cannot wait to learn more from Sammy. And I will review the chat, and afterwards we can reflect to see if anyone has any thoughts that they want to throw in there too. All right, Sammy, take us home, please.
Yeah, amazing discussion. You guys were just the whole time on top of it. And Ravi, I'm just so stunned about your ability to dissect such a complicated case into such an easy explanation and get those free tests, and maybe one of them is going to be positive. So they didn't get a PET CT. HIV was negative, by the way. I didn't mention that. A heavy metal screen was normal. Great idea with the instrument. Didn't even think about it. And what finally returned positive was the urine porphobilinogen, which was markedly elevated. And the delta aminolevulinic acid, the ALA, yes, was mildly elevated. Stool porphyrins were negative. And this led to a diagnosis of acute intermittent porphyria, leading to SIADH with this marked hyponatremia. And you guys were just on top of it. You were considering the presumed urinary tract infection as maybe not being one with the macrohematuria. A little clue was also that he couldn't tolerate the alcohol with protracted headaches and abdominal pain, which is also pretty typical for AIP. Yes, I'm having some teaching points if you want. Okay, then I'm just gonna
Before you do
continue.
that, I just want to thank you for, I mean, I think the case presentation was outstanding. You really had a poker face the whole time and laid out the
I was
data.
trying hard.
Yeah, you did a really good job. And what a humbling case. I mean, acute intermittent porphyria presenting without a background of recurrent acute episodes of abdominal pain is very unusual. So a very rare presentation of a rare disease. I'll let you do the teaching, but I think the way you presented it really maximized our reflection, and I cannot wait to go through the chat afterwards and learn from the wisdom of the crowd. But thank you so much.
Yeah, I think it's really a hard diagnosis because it's a rare manifestation of a rare diagnosis that's in medicine basically the most that's the most difficult diagnosis to get, and you guys were just on top of it the whole time. I'm just so, I don't know what to say. Yeah, for SIADH, it's one of the most common causes of hyponatremia, and the physiologic triggers for ADH secretion are low effective arterial blood volume, which Robbie already said, in combination with aldosterone, or a high serum osmolarity. And in SIADH, you have an inappropriate secretion of ADH, which leads to hyponatremia. And specifically because aquaporin 2 gets built into the collecting ducts, which leads to more water reabsorption, and you also need a gradient in the nephron to reabsorb the whole water, because there has to be a gradient. And you already mentioned the Core AM podcast. I was also listening to this and to that, and learned so much. And reasons for SIADH can be CNS disturbances, malignancies, like you mentioned, with small cell lung cancer, head and neck cancers, drugs. And I also think the risperidone that he received could also, yes, I think you have to think what is more important, treating the delirium or the hyponatremia. I don't know what are your thoughts about this. And another reason for high ADH is pain. So it's so important to give appropriate pain relief after an operation, because otherwise people can get hyponatremic, and that's not only because you don't want to have them to have pain, you don't want them to have pain, but also to stop the ADH secretion, pulmonary diseases, endocrinopathies like hypothyroidism or adrenal insufficiency. And for AIP, it's the second most common porphyria after porphyria cutanea tarda. And it's very important that you asked about family history, but it's important to know that it may be absent because it has a pretty low penetrance, although it's autosomal dominant inherited. And for the pathophysiology, heme is required for cytochrome P enzymes, and in AIP, they lack the enzyme porphobilinogen deaminase. And for example, everything that triggers CYP induction when you take oral contraceptives, when you starve, when you have stress, you have an increase in the cytochrome activity, but you can't really build cytochrome. And so the substrates get built up and then can get into the blood, can get into the CNS, and lead to secretion of ADH. And the classic triad is abdominal pain, neurologic dysfunction, for example, psychosis, polyneuropathy, and also sympathetic toxicity with tachycardia and hypertension, of which he only had the hypertension. And sometimes rarely can also cause SIADH due to the hypothalamic involvement and the dark urine, which was also the case here. And another pearl that I learned from my GI professor is that many patients, mostly it's women, wear dark underwear because they are ashamed of sometimes having, of more often having red urine. And so that's a clue, maybe somebody finds it useful. And my last pearl is that you can, on the height of bofabilinogen and delta aminolevulinic acid, you can determine what is more possible, if it's lead or if it's acute intermittent porphyria, because in one disease, the pre-enzyme gets stopped and then the other one gets high. I won't get into that, but yeah, that's from me.
Sammy, absolutely outstanding. I feel like you gave us an approach to SIADH that is probably a schema we should have on the website, and a great illness group for AIP and its mimickers. Thank you so much. That was such a treat to bring this case today. I can't wait to tell Reza what he missed out on. It'll be so much fun. But of course, to take us home, Gerline, the mic is yours, my friend. Thank you again for joining us, everyone. And I'll pass the mic to Gerline to reflect to the case and sign us out for today.
Yeah, thank you so much, Sammy, for the great case. I'm always humbled by acute intermittent porphyria. I know we had a previous case on VMR presented as well. So when we were approaching this case, we were first thinking about the hyponatremia as the chief complaint, and how usually we don't see patients that being the chief complaint. There's usually something underlying going on. In this case, it was the disorientation that the patient presented with. So we were thinking, is the disorientation and hyponatremia connected? Is one causing the other? Or are there two different processes going on in terms of the CNS being involved and causing both of them? And then when we're approaching hyponatremia overall, even though the phrase has the word natremia or sodium in it, hyponatremia is actually a problem of excess water and hypoosmolarity. So the sodium if you have hyponatremia, it could be due just due to hyponatremia, where you have proteins in the assay that can affect the test, or also other osmotic things such as mannitol, hyperglycemia, in contrast, which can lead to hyperosmolar hyponatremia. So the first thing when we have hyponatremia is to check the serum osmoles to see if it's hyperosmolar or hypoosmolar. And when we see a less than like 275 serum osmolarity, then we know we're in the realm of hypoosmolar hyponatremia. And then the next aspect is to check the urine osmoles, because that gives us a sense of if this is an issue of excess water. If someone is drinking a lot of water, like in primary polydipsia, you would have increased water being removed from the body as well. So your urine osmoles would be low. And then if your urine osmoles are high, then you're thinking about checking the urine sodium to see if this is inappropriate ADH secretion in the realm of SIADH. So the 5 contributors for hyponatremia that we think about are, is there increased water intake? Is there decreased solute intake? Is this thiazide diuretics causing it? That's the most common thing if a patient is on thiazides. That could also affect some of your urine serum study. So that's important to take into consideration. And then kidney disease as well as ADH, as I mentioned. So when we're thinking about inappropriate ADH, so ADH is usually secreted when you have decreased blood volume or increased osmolarity, but it can also be secreted because of nausea, pain, things that are common post-operatively. But in this case, the fact that the patient's post-op course, the sodium continued to worsen and didn't get better, kind of pointed us away from this being a normal post-op cause, but something more that was going on. So when we're thinking about other causes, we think about endocrinopathies like adrenal insufficiency. So in adrenal insufficiency, you have ADH is high because your cortisol is low, because normally cortisol inhibits ADH secretion. So with low cortisol, your ADH levels are high, which is leading to the SIADH picture. And then the other aspect when we were thinking about this case was what else is going on in this patient with the hyponatremia. In this case, the chronic constipation and the macroscopic hematuria were clues that there was something else. So when we're thinking about constipation, if it's chronic, and age is an important factor, this patient isn't as old that you would expect other causes of constipation. So when you're thinking about it, you think about if there's anatomic obstruction, like a volvulus or an obstruction, or motility issues. So motility issues could be most commonly due to medications like opioids or electrolytes such as hypercalcemia or hypokalemia. And then the other things that we don't want to miss are things that are affecting the muscle themselves, like hypothyroidism, scleroderma, and then neurologic causes like Parkinson's or diabetes. And then other causes to remember would be lead toxicity and acute intermittent porphyria. And then for AIP, in this case, there was the constipation, and then there was macroscopic hematuria. So when we're thinking about that, is the urine actually red because of hemoglobin, or is it something else? Could it be myoglobin and rhabdomyolysis, or is it just decoloration of the urine from something like AIP? If we were thinking it was actually hematuria and blood in the urine, then you could think about it anatomically, like, is this something in the kidney, with renal cell carcinoma being a sinister cause of hematuria, or is this something that localizes to the ureter, like a stone or the bladder? And then ultimately, the diagnosis in this case was layering on the chronic constipation, the discoloration of the urine, which led to the diagnosis of AIP. And Sammy already shared great teaching points on that diagnosis. So thank you so much for joining us.
Incredible job. Absolutely incredible. Whew. On fire, my friend. Thank you all for joining us today. Happy Friday. Thank you, Sammy, for a fantastic case, and for all of you to taking an hour on your day to come hang out with us. We'll hope to see you anytime this week. We're on literally every single day, and tomorrow we'll be hanging out with our friends for whom English is not a primary language, but everyone is welcome to join. We'll see you then.